um, um, bi- bi-weekly classes for BCPS. Today we have a lecture on chronic care in cardiology, one of the most important topic in the BCPS. And if you are working in a hospital or a retail pharmacy, or whether you are working anywhere as a clinical pharmacist or even a non-clinical pharmacist, so the most of the drugs, they are related to the infectious disease or cardiology. So Dr. Bilal, he will give us a lecture on the chronic care cardiology. So first of all, I would like to introduce all of you about Dr. Bilal. Dr. Bilal is working as in charge of hematology and oncology in Sheikh Khalifa Medical City in Abu Dhabi. He's a PharmD as well as the BCPS certified. So Dr. Bilal, the stage is over to you and you can start your lecture. Thank you.
Assalamu alaikum. Thank you, Dr. Rana. Uh, we will start with this chronic care in cardiology. As Dr. Rana told that this is the most related uh, to our daily practice and daily routine, this chronic care in cardiology. So let's start with this. I have nothing to disclose, no specific conflict of interest. I have no financial relationship to disclose. I will not discuss off-label use or investigational use in my presentation. So, uh, first of all, we should know about some key functions of the heart, particularly the normal functions of the heart. Um, when they get some abnormal, then we have to relate that how much abnormal are they and how can we can fix them. So there are some basic terminology we will just discuss in start so that we should be cleared when we will be starting the topic. Uh, this is blood pressure, cardiac output, cardiac index, stroke index, total ejection fraction, systemic vascular resistance, like this. So blood pressure is basically a product of cardiac output into systemic vascular resistance. Uh, when the heart pumps out the blood, it faces like a resistance from the vascular system. And in the young people, this vasculature of the body is more flexible, more relaxed. So when the heart pumps the blood out of the left ventricle towards the body, so the arteries can relax. But with the passage of the time, they become hard, and as the age progress, so blood pressure gets higher and higher. So cardiac output is basically product of two things: stroke volume plus heart into multiply by heart rate. Stroke volume is the volume of the blood which the heart pumps out of it in a single beat. Means one single time it contracts, the total volume which it uh, spills out, it's the stroke volume, and into the heart rate, it's the basically cardiac output. So in a healthy individual, this cardiac output is almost 5 to 8 liter per minute, and then the cardiac index is 3.8 liter per minute per meter square. Stroke volume index is 32 to 56 ml per meter square. Total ejection fraction 40 to 76. We will deal with mostly cardiac index to ejection fraction in this chapter. So there is systemic vascular resistance, preload, and these terms we should know: preload and afterload. Preload is basically end diastolic volume, means that when the heart is filling with the blood during the diastole, and the maximum the volume which it can contain at the end of the diastolic stage is the preload. And afterload, basically this is the force or load against which the heart has to contract to inject the blood. So these are basic terms I want to explain in the start. So we'll just begin. Our first topic is the heart failure. Heart failure is a complex clinical syndrome caused by any structural or functional cardiac disorder that impairs the ability of the ventricle to fill with or eject the blood. Basic purpose, the basic function of the heart is to pump out the blood. If in any condition, if he is not able to, the heart is not able to pump out enough blood which can perfuse whole body, this is called heart failure. And this can be any structural problem or like any functional, like electrical problem, means that sometimes we will discuss in the detail how these problems can arise. Types of heart failure, there are two types of heart failure. Heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. We will discuss in detail so that we know the pathophysiology. If we know the pathophysiology, we can easily fix that problem, and which medication can help. If we know the mechanism of the medication, it will help us to fix that particular point. So heart failure with reduced ejection fraction, defined as clinical diagnosis of heart failure and left ventricular ejection fraction of 40% or less. Means if in healthy individual, it's almost 60%. And if it is drops to below 40% ejection fraction, we will just discuss in detail what the ejection fraction is. Ejection fraction is equal to percentage. This one stroke volume divided by end diastolic volume multiplied by heart, multiplied by 100. So stroke volume means what the volume of the blood comes out of in single stroke. And end diastolic volume, what was the maximum volume at the end of maximum relaxation, means maximum diastole in the blood, multiplied by 100, means that how much volume is pumping out from the heart, and how much is leaving behind. It matters with this. It actually defines the ejection fraction. So here in this picture, the volume is pumping out, how much is the volume pumping out, and how much volume was in the heart chamber before this contraction is actually related to the ejection fraction. So in the normal cases, the heart, whenever contracts, it almost sends out almost 60% of the volume what was before the contraction inside the heart. There are two conditions: reduced ejection fraction and preserved ejection fraction. In reduced ejection fraction, the heart is not able to pump out enough blood, although there is a blood inside the heart, but he is weak enough due to some MIs, endocarditis, or hypertrophy. That heart ventricle walls does not have enough force to pump out of enough blood, about 60% of its inside, whatever is inside the heart is not able to contract fully to pump out to the normal volume. This is called reduced ejection fraction. With the preserved ejection fraction, if you can see the picture, sorry, actually the ventricle size reduces. If the ventricle size reduces due to the thickening of the heart wall, and there is not enough blood going inside of the heart, and if enough blood is not going inside the heart, the enough blood will not come out. So this condition is called preserved ejection fraction. So these two conditions will be deal with different way. So we will just go further. For further explanation, what this preserved ejection fraction and reduced ejection fraction will, with this example, you can see that in the healthy heart, this is the like a normal heart and healthy heart. In healthy heart, stroke volume is 70 ml, and 110 ml is almost, you can say that 100 ml is the end diastolic volume, means 70% of the total volume what was inside of the heart should come out in each stroke, and it is almost 64% is the ejection fraction. So if we go on the next level, which is like heart failure with uh, reduced ejection fraction, means that he is not pumping out enough blood, although there is blood inside the heart. So you can see that from 70 ml to it has been reduced to 44 mils. 44 mils out of 110 mils is just coming out due to the weakness of the walls of the ventricles. So its ejection fraction is reduced to 40%. So if this one is called reduced ejection fraction. On the other side, if you can see, uh, although the volume coming out of the blood is 44 ml, but inside the total capacity has been reduced, like 70 ml is the total capacity. It should be 110 ml. And from 70 ml, 54 ml is pumping out of the heart in every stroke. And although the ejection fraction is 63%, but it is still failed heart, because 44 ml stroke volume cannot perfuse the whole body. Although that's why I was trying to explain that you should know about this ejection fraction. Although with the 63% of even ejection fraction, the heart is failed heart, because it deals with the total volume what is pumping out. The total volume which is a healthy heart pumps out with single stroke, it's 70 mils. Below this will not perfuse the body, and it is considered as a failed heart. So I think, let me if I can minimize this one. Yes, okay. When actually in our normal human body, I will just try to hide this one also. 1 minute. I think it will not go. Anyway. I actually am not very expert of this hide. Yes, this one. Okay. In our when the heart is not pump out of enough blood, which can perfuse whole body, the body will not consider it is a that heart problem. The body will consider this one as per program, that there is the body is not getting enough blood. It means that there is less volume in the body. So the automatic system gets activated, which are called the compensatory mechanism, and they make the condition worse. So our primary focus in the management of heart failure is to stop these two compensatory mechanisms. Because in the natural way, when our volume in the volume of the blood in the body decreases, there are some like unnatural, like there is bleeding, or like there is um, dehydration conditions. When the volume in the body is decreased, these natural mechanisms are actually to compensate those problems if there is a bleeding or if there is a dehydration. So they try to preserve more blood in the body. So they try to stop the urination. The other try to constrict the blood vessels, so that more and more they can create a condition that the blood is enough in the body. Although the problem is not with the volume of the blood, it is problem with the heart. But the body consider it is like the problem is with the volume of the blood. So when heart is already failed and there is overfilled, over volume is more, the heart, it makes the condition worse. Yani, the first mechanism is ras angiotensin system, which is operated through the kidney, and you know very well. And the other for which we usually use to stop this ras, we use this ACE inhibitors, ARBs, like this. On the other side, this one is operated by the brain with the CNS, and it's through the norepinephrine, and it's works on the heart also. So both of these compensatory mechanism, we have to stop, so that we can relieve the burden from the heart. So our next slide, yes. You know, there is a classification of the heart failure, that what the heart is not able to perform the functions, that how much the condition worse is. They are classifying according to the symptoms of the patient. There are two actually parameters from which they classify the heart. We usually use this NIHAC functional classification: stage 1, stage 2, stage 3, and stage 4. This is the most of the time it is used, and they, when they ask in the BCPS question, they also mention about this classes only. So in class 1, the patient although has heart failure, but it is asymptomatic. There is no limitation in physical activity, but inside the heart has some problem. In the second stage, there is only slight limitation in physical activity. At the rest, the patient is fine. Means, yani, if the patient runs and gives there's some sports activity, there he can feel some limitation. He can feel breathlessness, symptoms of the heart failure. But on the routine activities, normal activities, walking, doing usual activities, the patient is fine. Then number 3 is there is a marked limitation, like if the patient is walking, even he can feel the symptoms, but at the rest he is asymptomatic when he is doing nothing. On the stage 4 is the last stage usually, and up till stage 3 it's like manageable. On the stage 4 it usually needs the heart transplant, and even the patient is experiencing symptoms even at the rest, whenever he even basically when there are two kinds of like heart failure. Well, it can be left ventricular heart failure, right ventricular heart failure. Whenever like heart is working as the same pattern as our routine like pumps which are pumping the water in our home. Whenever some pumps breaks, so the like fluid accumulates before this, yani. If in the start actually it happens that if the patient is feeling shortness of breath, and there is he is not able to breathe well, it means that it means there is a lot of fluid accumulated in the lungs, and this one is most related to the left ventricles, because left ventricles are taking blood from the lungs and supplying to the body. And if more pulling is towards the legs and towards the body, the blood is pulled in whole body, but the patient is breathing well, like he is not feeling any kind of problem during the breathing, then it means that it is a right ventricular problem. In the start, you can judge like this, but later on, when the condition become chronic, they both affect each other. So usually when the patient is like having left ventricular failure, the patient is not able to breathe, particularly when he is lying down. So because the volume of the blood which is pulled inside the lungs, when you lay down, it spreads in whole the lungs. But when you sit up, most of the time with one or two pillows at your back, the patient is able to breathe well. So the all volume of the blood in the lungs, it like stays down, like in the bottom of the lungs, and the rest of the lungs are free to breathe. And so they are also like evaluating the patient by his condition of breathing. So next, goals of the therapy: modify or control risk factors like hypertension, obesity, diabetes mellitus, all these factors. Because if there is hypertension, it is damaging the heart. Anytime patient can have MI. The patient wants to have the MI. It's hard. The walls of the heart becomes weak to pump the blood. Obesity is also contributed by diabetes mellitus. Manage the number B. Manage structural heart diseases like hypertrophy. When thickening of the heart, you should manage those heart diseases. Reduce morbidity, mortality. Prevent or minimize sodium and water retention. Eliminate or minimize heart failure symptoms. Block compensatory neurohormonal activation caused by reduced cardiac output. This one we have discussed in detail. Slow progression of worsening of the cardiac functions. Heart failure treatment. Basically, as I have discussed, we have to stop these two these two pathways, compensatory pathways, even from the first stage. So first stage start with ACE inhibitors. If the patient is not able to tolerate ACE inhibitors, you can switch to ARBs. You can go to the target dose, and then you can add the beta blockers. Even all the stages, If the conditions become symptomatic, then they can add diuretic to reduce the volume of the blood in all stages. It's almost treatment is almost similar. Start with ACE inhibitors, beta blockers. You can keep adding in each stage. You can keep adding the one drug. So anywhere these two major drugs, the other two diuretics, digitalis, these are just to control the symptoms. So this is the first clinical case. In the clinical case, there is most of the time there is a lot of information, and you have to uh, you have to be very careful which information is related to your question and which information you need to answer that particular question. So you have to focus only those drugs, only those lab values which are related to the question he is asking. He can give whole the profile, the normal profile. Patient has lot of problems, but you have to consider about only those parameters carefully which are which can help you to answer the question. So we'll start with this. JT is 62 years old man, height 72 inches, weight 85 kg, with history of coronary heart disease, MI 3 years ago. It means that his heart ventricle walls are already weak because there is already MI. Hypertension, depression, CKD, baseline serum creatinine 2.8 milligram per deciliter, peripheral artery disease, osteoarthritis, hypothyroidism, and heart failure. Left ventricular ejection fraction is only 25%. His medication now, you have got the idea what so many problems are with this. But among this, our related information is only left ventricular ejection fraction is 25%. His medication include aspirin 81 milligram per day, simvastatin 40 milligram every night, enalapril 5 milligram twice daily, metoprolol succinate 50 milligram per day, furosemide 80 milligram twice daily, celostazole 100 milligram twice daily, acetaminophen 650 milligram 4 times daily, sertraline 100 milligram per day, and levothyroxine zero point 0.1 milligram per day. His vital signs include BP 128/74 millimeter mercury, heart rate 72 beats per minute. Pertinent laboratory results include potassium 4.1 milliequivalent per liter, serum creatinine 2.8 milligrams per deciliter, and thyroid stimulation hormones 2.6 international units. His heart failure is stable and considered NEHA class 2. What is the best approach for maximizing management of his heart failure? This our question is in the last two sentences. His heart failure is stable and considered NEHA class 2. What is the best approach for maximizing management of his heart failure? We have to only look into what can be done in the management of the heart failure. So rest all information you can put on a side first. What you can our management should be, as I have discussed, we will start with ACE inhibitors and beta blockers usually to stop the compensatory mechanisms. Okay, so if we go these two things, there is enalapril 5 milligram twice daily and metoprolol succinate 50 milligram per daily. These two things are our concern in this slide. So if you see enalapril, and you can also go to the options, discontinue metoprolol and begin carvedilol 12.5 milligram twice daily. It is like out of question because patient is already stable and you will switch this one carvedilol, and particularly with this serum creatinine. Increase enalapril to 10 milligram twice daily. This can be considered because 5 milligram is not the target dose, particularly in heart failure. You can go up to the 10 milligram. This one is relative. At spironolactone we cannot give about serum creatinine 2.5 milligram. And add digoxin. Digoxin is, as I have discussed, digoxin and diuretics are always there to control the symptoms. The patient is already stable with the heart failure symptom. That's why the digoxin is not a choice. Spironolactone is not choice because of the serum creatinine. And first, we have to start with our to cover the compensatory mechanisms up till the target dose. So best option will be the increase in enalapril 10 milligram twice daily. It will further improve the heart failure condition. Next clinical case number 2 is Joe is a 64-year-old woman with an AHA class 2 non-ischemic dilated cardiomyopathy. Left ventricular ejection fraction is 30%. She presents to the heart failure clinic for follow-up. She is euvolemic, means there is no symptoms. Her medication include enalapril 10 milligram twice daily, furosemide 40 milligram twice daily, and potassium chloride 20 milliequivalent twice daily. Her vital signs include BP 130 over 80 millimeter mercury and heart rate 78 beats per minute. Her laboratory results are within normal limits. What is the best way to manage Joe's heart failure? If you can see that, as we have discussed, all heart failure patients should have two things. One, ACE inhibitors or ARBs, or the other thing, beta blockers. So this patient does not have the beta blockers. So we can go through the choices. Continue current regimen, increase in enalapril to 20 milligram twice daily, initiate carvedilol 3.2 milligram twice daily, initiate digoxin. Digoxin is for the symptoms. The patient is euvolemic, the patient is fine. But for to reduce the morbidity, mortality, we have to add the carvedilol. So C will be the answer for this one. That's why I was trying to explain the mechanism so that you should know which are the first two choices, how we have to control. So these are, two questions are related to our to stop those compensatory mechanism. So that's why they have to initiate carvedilol 3.12 milligram twice daily. After this, if the patient is not stable, then you can increase the dose of enalapril, or you can switch the carvedilol to metoprolol, whatever it is. So right now we have to start any beta blockers because there is no any beta blocker in the medication. So our next topic is arterial fibrillation. Arterial fibrillation is a condition in which it is all similar to the heart failure, but this one is like sometimes it's for a very short period. This one is not like related to most of the time uh, chronic. What I can explain, like this one is more related to electrical problem, yani. So with symptoms, some patients have no symptoms because the heart is still, although he is not operating on the full capacity, because whenever the heart contracts, there is electrical system which cause polarization, depolarization, and pumps the heart. If the electrical system is weak, basically this system makes the heart to pump. If it is a weak, but still he is pumping out enough blood to perfuse the body, the patient might not have the symptom, but there is problem in his electrical system of that heart. His means not operating at 100%. The potential symptom that may be present to some degree include the following: palpitation, chest pain, dyspnea, fatigue, lightheadedness, rare cases of thromboembolism event. Rare thromboembolic event happens because when there is arterial fibrillation and heart is not pumping completely, some parts are really not pump enough that they can move the blood, and blood pools in some portion or some parts of the heart where there is problem in the electrical activity of the heart. Where it pools, if the blood stasis occur anywhere in the body, it gets clot. So if is this emboli, this clot goes to the brain or goes to the lung, they can make like PE, they can cause stroke. So these are rare thromboembolic events are there. So pathophysiology of fibrillation is this one. Like in the normal SA node generates the electrical current, like there is electrical wave which causes the contraction of the heart. It goes through the arteria first, arteria contracts, there is AV node which delays the current from AV node to ventricles, and it also help if the AV node is there, electrical current will go once in the heart and whole heart will contract. This like stages contraction will not happen which is necessary. When first artery will contract, it will pump the blood into the ventricle, then the ventricles will contract, it will pump the blood to the legs and to the body. So this one by one contraction occurs due to the AV node. AV node delays this one. If there is some problem in this electrical activity, the heart has problem with coherence, with symmetry. It cannot contract with force and with rhythm. So this really affects the heart function, and you can see that in this there is abnormal P waves, QR waves. So in the ECG, it's very visible changes happen. So management of AFib is like pharmacological therapy, ventricular rate control, rhythm control, pharmacological cardioversion. Uh, we if problem can be like if the current is this SA node, AV node is not controlling the current flow of the current is flowing very frequently. The ventricles are contracting after the current, and it's beating, the heart is beating at very high rate, like some 200 150 beats per minute. So it can the heart is not getting enough time to relax and to fill with the blood, and then he will pump out the blood. Because if he will not pump out the blood, so the patient can go in the syncope, the patient can collapse. So ventricular rate control, we should like let the heart beat around 80 beats per minute, so that heart can be filled with the blood first, then it will contract to pump out the blood. Then the rhythm control, it cannot be like it will contract in 1 minute like 4 times, and the other minute it will not contract anymore. So rhythm control is also should be there. Pharmacological cardiovariant, sometimes this cardiovariant, we have to reverse back this normal function of the heart. It is called the cardiovariant. Antithrombic therapy we should give, because as I have told, if the heart is not contracting properly, the blood stasis can happen inside the heart, and there can be emboli, there can be thrombosis, and this can be lethal. Non-pharmacological therapy, electrical cardiovariant can be given, AV node ablation, and pulmonary vein ablation. These all are the points where sometimes electrical current starts generating. So by some devices, they just either it's like heat therapy or cold therapy, they make those cells dead. Because if any cell is working abnormally, it's better not to work, better it should be dead. So they just do this therapy to stop these abnormal current generation in the heart. Ventricular rate control, goal heart rate, resting heart rate less than 80 beats per minute is reasonable in symptomatic patient. Class 2A, these are antiarrhythmic classification. This topic will be discussed in detail in the acute care, but I will only touch those points where we'll cover this section. A more lenient rate control, resting heart rate is 110 beats per minute, may be reasonable in patients who are asymptomatic and have preserved ejection fraction. Beta blockers, non-dehydropyridine calcium channel blockers, verapamil, diltiazem, because they are mostly working on the heart as well as on the peripheries, digoxin, amiodarone. Rhythm control, oral antiarrhythmic agents to introduce or maintenance choice of agent depends on the patient comorbidities. Class 1 antiarrhythmics, flecainide, propafenone, they have 80 to 90% efficacy. These are the first line therapies for the patient without structural heart disease. So structural means heart disease are those where there is hypertrophy, like heart walls get thicker, or there is some dead tissues. If it is not there, the flecainide, propafenone is the first choice. Class 3 antiarrhythmia, amiodarone, sotalol, dofetilide, dronandron. AFib management plan is this one. There are two kind of heart. First, the heart with no structural disease. the other heart with a structural disease. If the heart has AFib, which has no structural heart disease, there is the option that you can start with dofetilide, dronidron, flecainide, propafenone, sotalol. And if it is not working, you can go to imiodaron. And if it is not working, you can go to the catheter ablation. You can put the catheter in the heart and you can fix the current problem. Structural heart disease. If the patient had coronary heart disease or heart failure, there are two different managements. If the patient has coronary heart disease and we can go either directly to the catheter ablation, or we can first try the medication dofetilide, dronidron, sotalol with the patient who has coronary heart disease. And then imiodaron. If imiodaron doesn't work, the last choice is catheter ablation. Similarly, with heart failure, we can either go to the directly catheter ablation, or we can go to amiodaron and dofetilide first. In heart failure, the selected choices are amiodaron and dofetilide. You have to memorize these things because they are usually coming in the questions, that in what condition, which is the preferred choice. Uh, 1 minute, just I will slow down my AC. Okay, anticoagulation strategies surrounding cardioversion of atrial fibrillation. Whenever there is a atrial fibrillation, as I have discussed, the blood pools in some areas of the heart where there are not proper contractions, because the contractions are necessary to uh, to keep the blood moving in the heart and in the blood. And if there is fibrillation, means the heart is not contracting properly, and there is stasis of the blood and blood can clot. If we have to reverse the condition of arterial fibrillation, and after if there is some stasis and there is some coagulation, this blood will also start moving, and it can go to either the lungs or to the brain, so it can cause problem. That's why they have put some guidelines how you will fix arterial fibrillation, and when you will be fixing arterial fibrillation, what kind of anticoagulation therapy you have to give before fixing and after fixing. So there are two um, uh, options. Either arterial fibrillation has started less than 48 hours, or if the other one, if it is a more than 48 hours. There are two different stages. If it is less than 48 hours, pre-procedural AC therapy initiation, or before every cardioversion, you have to initiate before the cardioversion. You can give unfractioned heparin, low molecular weight heparin, and a pixaban loading dose, and you can go to for the cardioversion. Means just before the before the procedure, you can give these anticoagulants, and you can start the cardioversion. Other than 4 weeks, you have to give the post procedural AC therapy. This one, vitamin K antagonist like warfarin or Novac. Long-term AC therapy based on Chadwa score. This one you will also discuss discuss in detail in anticoagulation chapter. This Chadwa score. So we will just briefly discuss over here. The other thing, if it has been more than 48 hours that it is the arterial fibrillation, so then there are two options. First, we have to play echocardiogram, is tracheal echocardiogram guided procedure. If you will put, if you will see inside the heart through the trachea that whether there is some clot or no, then you can, if there is no any clot, you can just follow pre-procedural AC therapy and you can continue the therapy. If it is a not guided, if there is no facility to do the echocardiogram to see any coagulation, then you have to go for 3 weeks before cardiovarian 3 weeks, you have to give anticoagulant, then you can go for the cardiovarian. So then again, post procedural therapy, same 4 weeks for all patients. Long-term anticoagulant therapy is always based on the CHADWA score. You calculate the score. If it is a more than 3, then you 3 or more than 3, you have to give long-term anticoagulation therapy. Antithrombic therapy, this is the CHADWA score, how they calculate this. There are different parameters of calculating CHADWA score, as I have discussed that. You will discuss in detail in anticoagulation therapy. This stratification treatment determination is based on CHADWA score table. This one of note, 2008 chest guidelines for anticoagulation in arterial fibrillation no longer recommended antiplatelet therapy alone. Previously, antiplatelet therapy was considered as enough. If the patient has a fibrillation, later on they said that there are more risk of stroke and pulmonary embolism with the only antiplatelet like aspirin therapy or clopidogrel therapy. You have to always add anticoagulation, antithrombic therapy with this antiplatelet therapy. So in this way, you will calculate the score like congestive heart failure or left ventricular ejection fraction less than 40% has 1 score, hypertension has 1 score, age 75 and above has 2 score, diabetes has 1 score, stroke or transient ischemic stroke, transient ischemic attack, thromboembolism in the past has 2 score, vascular disease has 1, age 65 to 74 has 1, sex category has 1, female. So they have most of the time 1 or 2 questions are always from this chart. So that's why I have put this one, one question we can discuss. PM is 52 years old man, height 70 inches, weight 116 kg with a history of hypertension, a transient ischemic attack 2 years ago. He visits his primary care doctor with the chief concern of several weeks of fluttering, feeling in his chest on occasion. His current medication include metoprolol, tartrate 50 mg twice daily, aspirin 81 mg per day. He is adherent to his regimen and has health insurance, but he does not like to make 3 hours trip to his primary care provider. His laboratory data from his past visit were all within normal limits. His vital signs today include BP 130 over 78 millimeter mercury, heart rate 76 beats per minute. All laboratory values are within normal limits, and electrocardiogram ECG reveals an irregular rhythm with no P waves and heart rate of 74 beats per minute. A diagnosis of atrial fibrillation is made. What is the best approach for managing his atrial fibrillation at this time? So, uh, as we have discussed that uh, whenever there is atrial fibrillation, we have to start uh, mm, uh, uh, anticoagulation therapy. So for anticoagulation therapy, again, how we will start anticoagulation therapy? We will start after calculating the score. If it is qualifies with this score, with 3 or above, we have to start the anticoagulation therapy. So let's calculate the score for this patient. Age 65 to 74, congestive heart failure, left ventricular ejection less than 40%. Okay, so this patient uh, has hypertension, but not the heart failure. So no point for this. Other hypertension, it has hypertension, history of hypertension, it has 1 score. Other age, if there is no score for the age. The other thing, the patient has transient ischemic attack 2 years ago. So it means that 2 score for this. The patient has already got 3 score. So it means that you have to start the anticoagulation therapy. So first of all, the most important thing is this one, that you have to start the anticoagulation therapy, because these two things are not treating the atrial fibrillation. If he has to treat the atrial fibrillation, The choices will be amiodarone, dofetilide like this. With digoxin, with diltiazem, the patient is not being treated for atrial fibrillation. The purpose of this question is to tell us about that what kind of anticoagulation therapy we supposed to start. So there are two options for anticoagulation: warfarin 5 milligram per day and titrated to goal of INR of 2.5, and began dabigatran 150 milligram twice daily. Actually, first choice is for this question is warfarin, but sometimes they mention such information in the question which you see that it's not relevant, but this one is supposed to be uh, included. It's this supposed to be considered when you are answering this question. Like this information, he has mentioned that uh, he is adherent to his regimen and has health insurance. Means that if he has health insurance, the cost is not a problem for him, and cost is not a problem for him, and even he has to take twice daily some medication, here is not a problem because he is already taking his medication. The other thing, but he does not like to make 3 hours trip to his primary care provider. Means that for warfarin there is strict monitoring about the INR. The patient is not willing to come for the monitoring of the INR. So it means that although the first choice is warfarin, sometimes people ignore these points and go warfarin straight. But you have to sometimes go to the second line, second choice, considering the facts related to the person. So that's why you have to the answer of this question is began dabigatran 150 milligram twice daily. So there are such kind of tricks in the question which you have to consider. So next clinical case number 4. HD is a 67-year-old man with a history of hypertension and atrial fibrillation for 4 years. His medication included ramipril 5 milligram twice daily, sotalol 120 milligram twice daily, digoxin 0.125 milligram per day, and warfarin 5 milligram per day. He visits his primary care physician today after being discharged from emergency department with increased fatigue on exertion, palpitation, and lower extremity edema. His vital signs today include BP 115 over 70 millimeter mercury, heart rate 88 beats per minute, and all laboratory results are within normal limits. However, his lower extremity edema has worsened. His INR is 2.8. His ECG shows atrial fibrillation. An echocardiogram reveals an left ventricle ejection fraction 35 to 40%. HD physician would like to continue rhythm control approach. What is the best treatment option for managing his atrial fibrillation? So the patient was stable with hypertension, everything, but recently the patient has got heart failure. So whatever medication he was taking, you have to consider what is the guideline for management of heart failed uh, therapy. Means as the heart, now we have to consider about this heart failure. Either this in heart failure there are two options, amiodarone and dofetilide, because the patient is coming under this category for the management of atrial fibrillation. So let's get back to this question. So what are these? Discontinued sotalol and begun metoprolol succinate. This one is like, although you have to discontinue sotalol, but metoprolol will not help in this. Discontinue sotalol and begun donidron. This can be the option, but in heart failure, particularly, we have a amiodarone and dofetilide option. Discontinue sotalol and begin amiodarone 400 milligram twice daily, tapering the goal dose of 200 milligram per day for next 2 weeks, 6 weeks. So this is the choice, C choice. For this, discontinue sotalol and add metoprolol twice milligram. The other options cannot be, because in heart failure, the recommended option is only amiodarone and dofetilide. So you have to keep in your mind that in what condition, which regimen you will choose. Next topic is our hypertension. Hypertension is persistent non-physiological elevation of BP is defined as having shortness, systolic blood pressure of 140 millimeter mercury or greater, having diastolic blood pressure 90 millimeter mercury or greater, taking antihypertensive medication, or having been told at least twice by the physician or other health professional that one has hypertension. Primary or essential hypertension 90%. No identifiable cause. Obesity contributor. Evaluate sodium intake. Secondary hypertension. Primary hypertension always have idiopathic, means there is no any cause, but there is a hypertension. But secondary hypertension always you have some cause to blame, that this Cushing syndrome, pheochromocytoma, primary adverse event. 90% of the time the cause is unknown. Yani. So benefits of treating elevated blood pressure: decrease risk stroke. These are the benefits. It's really worth uh, discussing, because in our community, particularly in rural areas, people don't consider hypertension as a disease. They don't take it seriously. It's a general perception in our area in Pakistan is this one: until unless uh, some disease cannot make you lay on the bed, you will not consider it as a disease. You think that you are more stronger, but in fact the heart, this is a silent killer. If someone has hypertension, he needs proper counseling, although he cannot feel, but there is a damage being made by this condition. If you treat like hypertension in the early stages, it can decrease risk of stroke by 35 to 40%, decrease risk of MI by 20 to 25%, decrease risk of heart failure by 50%. Actually, our population, until unless he does not undergo stroke, MI, or heart failure, they will not realize that they have some problem. Classification of hypertension. This one, there are stages: normal, elevated, high blood pressure, and high blood pressure hypertension stage 1 and stage 2. Then hypertensive crisis or hypertensive emergency. Any If the patient fulfills any of the criteria, he can come in this stage. If he is filling both, it is unanimously in this stage. But if he is fulfilling only one box or one stage of either systolic or diastolic, then it is called isolated, like systolic hypertension or isolated diastolic hypertension. So less than 120 and less than 80 is normal these days. Elevated 120 to 129, and the diastolic less than 80 still. High blood pressure stage 1 is 130 to 139 or 80 to 89. And high blood pressure hypertension stage 2, 140 or higher, 90 or higher. Usually in stage 1, the patient is being treated with one medication, and in stage 2, the patient needs two medication to treat the blood pressure. In hypertensive crisis, it's emergency case, because anytime any event can happen, and it can cause like either the stroke or either the MI. So in hypertensive emergency, or should be treated in the emergency department. So what kind of medication we will start, again based on the comorbidities of the patient, what the other problems he has except hypertension. Like if the patient had diabetes, chronic kidney disease, stroke, or transglycemic attack, coronary disease, heart failure reduces ejection fraction, heart failure preserved ejection fraction. This regimen will be according to these comorbidities of the heart failure. There is some detail of this in this table. So clinical case number 5, WD is 55-year-old white female who was recently admitted to the hospital with acute myocardial infarction, which was treated with stent. She she has a past medical history of hypertension and gut. She is visiting your clinic today for management of her cardiovascular medication. Her vitals today include BP 152 over 86 millimeter mercury, heart rate 82 beats per minute. Her labs are all venal, including sodium 140 millicolon per liter, 4.5 millicolon, potassium, serum creatinine 1 milligram per deciliter. Her current medication regimen includes clopidogrel 75 milligram daily, aspirin 81 milligram daily, and atorvastatin 40 milligram daily. What is the most appropriate approach to manage her heart failure? So this patient has already transient ischemic attack, acute myocardial infarction, and as per is reading 152, it is a stage 2 hypertension, particularly systolic stage 2 hypertension. First of all, the patient should have two medication. As I told, in stage 2, the patient needs two medication. So two medication are B and C options. Such kind of questions always usually come that when they deal with the race, because in American population it's a mixed race with two major population, white and black African race are there. In African, more amlodipine calcium channel blockers are more effective than the ACE inhibitors. But in white people, the ACE inhibitors are more preferred choice than the calcium channel blockers. If it would be a black female, the answer would be melodipine and metoprolol. Because this is the white female, that's why the answer is lisinopril and metoprolol. Because this patient does not have any antihypertensive therapy. So in this current regimen include clopidogrel, aspirin, atorvastatin, only three medication. You have to add two more medication to control the hypertension, and two medication is according to the race of the patient. Dyslipidemia. Dyslipidemia is an abnormal level of cholesterol and other lipids, also called fats, in the blood. Goals of the therapy: reduce CV morbidities and mortalities, achieve LDL-C goals when appropriate. Non-pharmacological recommendations, non-pharmacological, usually you have to change your lifestyle, eating habits, drinking habits. You have to include exercise in your, these all are non-pharmacological. Pharmacological recommendation, therapy recommendations are divided into patient management groups: secondary atherosclerosis, vascular disease prevention, severe hypercholesterolemia, like if LDL-C is above 190 milligram, diabetes mellitus, primary prevention. The patient are managed considering these four factors. They calculate atherosclerosis, vascular disease risk factor, hypercholesterolemia, diabetes mellitus, primary prevention. There are tables how they manage this one. On first stage, they start statins. Second stage, they start ezetimibe. Third stage, they start PCSK9 inhibitors. They do this step by step. If they are not able to achieve the desired goal with one step, they go to the second, next step, and next step. So there is a pooled cohort equation. This is used to calculate the risk of atherosclerosis vascular disease. There are different parameters, components of this pool cohort equation. Usually, no one knows about what score give to each parameter, but there is application in the mobile. You can calculate online atherosclerosis risk factor. So dyslipidemia management, that as I have told, that patient management group, they have divided the patient in four stages: atherosclerosis, vascular disease risk factor, severe hypercholesterolemia, next diabetes mellitus, and then primary prevention. So the color, there is a color scheme which indicates that if it is a light brown, light gray color, it is strong recommendation. If it is like a little darker, it is moderate recommendation, means therapy is reasonable. And if it is the darkest, the therapy may be considered. So we can just have a look on this, how we read this one. If atherosclerosis vascular disease risk we calculate, and if the patient comes with very high risk, usually this is the classification. If low risk less than 5%, borderline 5 to 7.5%, intermediate risk 7.5 to 20%, and high risk is greater than 20%. This is the risk classification of ASCVD score. If very high risk, if the patient has very high risk, multiple major events or major events plus multiple high risk conditions, you have to start high intensity statins. And on the first stage, if LDL-C is greater than 70 milligram per deciliter after starting the high intensity therapy, then you have to consider ezetimibe. And after ezetimibe, if LDL is still greater than 70 milligram per deciliter, non-HDL is still greater than 100 milligram per deciliter, then you can consider PCSK9 inhibitors. So the recommendation is very strong recommendation that you have to do. This one is both are reasonable to start. So next, if not very high risk, this is very high risk, not very, then you have to go for the age also, because with the age there is a muscle mass you have to consider with the statin, and the statin are usually losing the muscle mass. So if it is a less than 75 years old, high statin therapy you can consider, and if it is a greater than 75 years old, because there is less muscle mass of above 75 years, you can go moderate to high intensity therapy. Next level is this one, you can consider ezetimibe only if LDL-C is greater than a 70 milligram per deciliter. Severe hypercholesterolemia, this one is age 20 to 75 years. Then you can go up to maximum tolerated statin therapy is recommended. And again, then ezetimibe you can start, and then you can go to PCSK9 inhibitors in this condition. Next, if the patient is with the diabetes mellitus, they categorize the patient in three groups: age 20 to 39, 40 to 75, and greater than 75. And they deal according to the age group with diabetes mellitus. And then primary prevention, if the age is 40 to 75 years old and LDL-C is 70 to 189 milligram per deciliter, then you can calculate 10 years ASCVD risk score using PC, this pool cohort equation, and determine the risk estimation plus risk enhancer favor statin therapy. Then if low risk, borderline, intermediate, in high risk, you will go for high intensity therapy. So this is a last clinical case. MM is a 63-year-old white woman who just finished 6 months of diet and exercise for dyslipidemia. She has history of hypertension, diabetes mellitus, and asthma. She smokes one pack of cigarette and drinks 3 beers per day. Her mother had hypertension and suffered an MI at age 42. Her father had hypertension, diabetes mellitus. Her medication are albuterol, meter-dose inhaler, lisinopril, metformin, linagliptin, and calcium carbonate antacid. Her vital signs include BP 134 over 84 millimeter mercury, mm, heart rate 75 beats per minute. Her laboratory results are as follow: HDL 38 milligram per deciliter, LDL C 134 milligram per deciliter, triglycerides 86 milligram per deciliter. TC 209 milligram per deciliter, hemoglobin A1C 8.6%. Her pooled cohort equation estimate 10-year ASCVD risk 27.8. What is the most appropriate next step for MM? So first of all, this patient has diabetes mellitus, will go in this. And with this, the patient ASCVD score is 27.8, means it's very high score. In this whole long uh, question, the concerned information is very limited. Like the patient has diabetes mellitus, age is 63, and ASCVD score is 27.8. So will go directly to diabetes mellitus, age is in this group, and patient with multiple ASCVD risk factors. So you then if the patient has the multiple risk factor, high intensity statin therapy is recommended. If moderate intensity statins are only recommended if the patient ASCVD score are less, in like 10%, 7.5%, but this patient has already uh, 27.8 ASCVD risk factor. So in this condition, even if you take this patient in here, where the ASCVD score, you have to go high intensity therapy. So that's why for this patient, even in two, if you can evaluate this patient even in two categories, so the patient needs initiate high intensity statin therapy. This is the choice C. So that's all for today. Although this is very long topic, but due to the time constraint, I just try to discuss the most important and confusing information. If there is any question, you are most welcome.
Ji, Assalamu alaikum. If there is any
Well,
question, you may ask. In the meanwhile, I will talk to Dr. Bilal. Sir, कैसे हैं आप? बहुत
जी
जबरदस्त हमेशा की तरह।
बहुत शुक्रिया, आपने मौका दिया इस बार भी, तो ये खुशी होती है जो
नहीं
कुछ
नहीं नहीं
हम कर सकते हैं वो इंफॉर्मेशन